So thanks very much for coming to Achieving Consultation Excellence. This is incredibly important in the current environment of NHS cuts. Hello, not too late, feel free to take a seat if you want, or unless you're just passing through. It's incredibly important in the current environment in the NHS. How do we optimise our interactions with every single patient that we come into contact with? And it is a challenge. Before we start, I'd like to start with Hippocrates, and I thought this was a fairly good picture of him, slightly different from the conventional ones. And there's a couple of quotes, and I'd like you guys to think, how often do we apply this in our interactions with patients on a daily basis in the NHS? And the first one is, cure sometimes, treat often, and comfort always. And the second one is, it is more important to know what sort of person has a disease than to know what sort of disease a person has. Obviously, Hippocrates wasn't around NHS wasn't around in time of Hippocrates. So it does put a slightly different spin on those quotes, but it's useful to think about in terms of what we're actually doing with our patients and the interactions that we are having with them. We're forced into seeing people in 8 minutes or 10 minutes in GP. We're forced into making a decision in 4 hours in A&E, or a decision in 3 hours and seeing them within 4 hours. And you know, what does that say for the state of medicine as a profession at the moment? I don't know if the handheld mic's around. What we're going to do is just quickly dot around the people in the room. If you just introduce yourself and say what your name is, where you're from, what kind of your job role is, because that would really help me in terms of pitching the talk so it's relevant to you guys.
Corina, Senior Clinical Fellow Medicine, Bristol.
Okay, thank you.
I'm Joe, SHO at the Stroke Department. I'm a consultant on endocrinology and diabetes from London.
Thank you.
I'm Joe, a counsellor.
I missed that, sorry, say again.
Counsellor.
Cancer, okay.
Hi, I'm Becky, I'm an FT in Sheffield.
Hey, you're right.
I'm Ellie, I'm an SHO in A&E.
Okay. SHO in A&E. Okay.
I'm a consultant cardiology.
Okay, great. If you guys want to sit forward a little bit more, feel free, because then we don't have to worry too much about the handheld mic, but if you come forward, that'd be great. So what I'd like to do in this talk is briefly cover my atypical career path. And the reason behind that is being the stuff that I do now, in terms of a lot of you guys may well have seen my videos. I spoke to the chap who's a consultant, just checking his emails here. He's not in the talk, but he's so focused in the emails, it's amazing. Little smirk. He recognised the video, so that was good. And it's not one of those things that I've just decided, I've woken up and decided to do. There has been a gradual progression, and I'll talk to you that briefly. I'd like to revisit some cases and highlight and exemplify some NHS problems, and also discuss how the NHS challenges impact on our consultations. And then it's kind of over to you guys and see what solutions we can do to it, how we can influence consultations when we're in a clinical setting. And there's a few little tips at the end, some consultation tips. So from an academic background, this is me pretty much. I went to medical school at 18. Thankfully didn't get kicked out. Eternally grateful to the University of Leicester for not kicking me out. Some of the content that I put out now, maybe they wish that they did, but they didn't. And then I did F1, F2 and CT1, CT doing core surgical training. And in 2013, my career took a slightly different trajectory, in the sense that I left core surgical training to go and be a teaching fellow in Lincoln. So I'm a teaching fellow, studied for medical education masters. At 2015, I was meant to go off and do a proper job, and I didn't really want to, so I really enjoyed teaching as well, so I wanted to stay. And then now they're funding an MBA, which I'm eternally grateful for. So a little old district county hospital funding an MBA, so that's cool. And that's at the University of Nottingham as well. I've felt more at home at business school than I have at medical school, and in terms of an entrepreneurial background, I guess that would kind of make sense. I started out in Specsavers at 15 and carried on working there until 22, all the way through medical school. And then I've done some locuming, a fair amount of locuming, about 2,500 hours not out, in addition to a full-time NHS job since 2009. I set up an educational company, so there's lots and lots of free educational resources. I felt quite bad locuming actually and doing something that I would for free because I love it, so I invested that into educational resources. And then November 2015 happened, this time last year. I can remember driving to the AGM with my best mate Jack, who's also my Jedi Master, and we said, wouldn't it be great to do a video that explains the junior doctor contract dispute to members of the public? So we made a Jedi video, and the Mirror ran with it, and then I've done some other media stuff since then. So what does a typical day look like for me? Well, I'm based in Lincoln, I work in undergrad, I teach medical students day in, day out. I locum in A&E and also do some A&E in Lincoln as well. And then evenings and weekends I put on CPD accredited courses and do lots of Facebook videos and stuff. I'm in an incredibly privileged position in terms of the stuff that I've been able to do. When I went to medical school, I would not have expected to be doing the things that are shown on that. But the common denominator is medical training has set me up to be able to do these things, because this is communication skills on the broader scale, whether it's Sky or BBC or interviewing Corbyn or speaking at a rally. It's communication skills that have been taught to me by medical school, essentially. But also what I found quite challenging is how from 2002 to 2016, my earliest experience of the NHS was in Specsavers, in the sense that I was selling glasses to people, and there are NHS glasses, and there was a completely different environment in Specsavers to what there was in the hospitals that I was working in as a medical student, and to the hospitals that I work in and as a doctor now. And that environment is basically because there's the NHS, we've got a monopoly, you know, you can't go elsewhere, you've got to go there. Whereas in Specsavers, if they don't have the communication skills, if they don't have the equivalent of the consultation skills, they don't survive as a business and they go bust. It was also an excuse to get the Watford monopoly picture in there as well. So, what do you guys think the public's perception of the NHS is? We've got a handheld mic, I don't know where that's gone. Okay, well, we're thinking about it. Whatever the public's perception is, the morning before they have their MI, they have their stroke, they come into hospital and they're not expecting to come into hospital, they're reading this and they're digesting this. And this is some of the trash and the garbage that What Med Media is interested in correcting and actually putting forward the view of healthcare professionals and, you know, engaging with patients. But we need to be aware that when people come into hospital, they're at their lowest point and they're unwell. We're working in a pressurised environment in the NHS where we struggle to give the best of ourselves, and there's all of this stuff in the background that's going on. Now, the next slide is the game changers. So there's a couple of things that have changed the way we practice medicine in the UK. Have you guys got any ideas? There's one of them have got a stand just over there, you might have seen. Anyone want to say what has changed the way that we practice and will change massively? Okay, so the first one is Hello, my name is. I think the fact that a campaign can have this much national traction is a disgrace, because it shows we as a profession are so bad at introducing ourselves, saying who we are before doing lumbar punctures, breaking bad news of cancer, daily interactions with people. So Kate Granger did a great thing in this, and that's an absolutely amazing thing, and I hope it lives on for a long time. But then the other game changer is I Want Great Care. Can we just have a quick show of hands for who knows what I Want Great Care is? No, nobody knows who. Okay, so we'll spend a little bit of time on this. This is basically rate a trader or trust a plumber for medicine. Okay, if you're a fully qualified doctor in the UK, so F2 and above, your name is on iwantgreatcare.org, and it's scary, isn't it? It's scary. You can have an absolutely horrific consultation with somebody through reasons that are not your fault, because the A&E department is rammed and there's not enough beds, you have to see somebody in a corridor. And then because the environment has changed, which I'm pro the environment changing, that we're introducing ourselves, but because the environment has changed so much, if you are the doctor that does not introduce yourself to a patient, you will stick out like a sore thumb. And if they're upset with you, then you will find a 1-star review going on iwantgreatcare.org. And every year with appraisal, and then every 5 years with revalidation, that's a massive problem. And some of the 1-star reviews on that are like, you know, Dr. X might know their stuff, but they have no people skills. They have no charisma. They don't care. They've got the empathy of a stone. Actually, in fact, a stone would probably have more empathy. These are all the kind of reviews that people will put on there. So medicine is changing, and I'd like to consider the consultations that we do, and I've got some cases to talk through about in a sec. I also found this, which kind of helps me, doesn't help me, but it makes me happy in the sense that back in 2002, when I was in Specsavers, I was amazed by Mystery Shopper, and I was hidden camera recorded, and we were messing around at the till, and the guy that was this dispenser got like 30% because we were joking and laughing and stuff, and it was a real eye-opener in terms of being in that clinical type environment, but have people coming in and pretending to assess you, pretending to be patients, but their primary purpose is assessing you. So Stoke and North Staffordshire, I've seen this, NHS Mystery Shopper, and I think that's the kind of thing in the climate that we're working in, which is stretched and targets and very pressurised. It's things like that will help improve the service that we give. I'd like to know what affects your guys' consultations. We've had lots of people in A&E predominantly, so I could talk about that. But can you just shout out some stuff that affects what your interactions with patients? Okay, so time pressures, yeah. So what are the time pressures in your? Yeah. Yeah. Okay. So I'll just say to everyone, if we can get the handheld mic, it'd be amazing, because then you guys can pass that around. It makes it a little bit easier. But so yeah, time pressures in A&E. One of the cases that I'm going to talk about is how time pressures can negatively impact on you guys, because all that happens is managers, and I want to change this because I'm doing an MBA, so I want to change this, and I think it can be changed. But managers will just turn the screw and say, well, you've got to work harder. And in one A&E department that I worked in, I saw 20 patients on Saturday in 9.5 hours, one every half an hour, and I saw 19 on the Sunday. I saw one every half an hour. So scene, history, examination, clerks, plan written up. This is all in FIT, so that first assessment, so that anybody, a medical student, no disrespect to medical students, but anyone, no medical training whatsoever, a first year medical student, even a work experience student, could pick up the plan, look at the notes and say, oh, chase bloods, if this, do that, if that, do that. And the response that I was met with by somebody quite high up in the department, head of the department, I think, said something like, well, why don't you do it? You should be seeing them every 10 minutes. So what are we, as a medical professionals, why are we not standing up to this and saying, well, actually, you know what, if you want to do that, that's fine. I am in a privileged position in the sense that when I go into trusts and locum, because I do it for enjoyment, it's a little bit of an interesting dynamic, because they say, oh, we won't fill out your timesheet, we won't, you know, you need to stay. And well, I don't need to stay. If I'm tired, I'm not going to stay. I'm not going to do it. And the best one was, there was this locum professor who, we had a patient that came in and they had metastatic cancer, came in with a PE, so low, really low SATs, and I wanted to get a DNAR form signed. Now, the way that hospital decided to do it is this guy had a letter in the post saying we're going to like to sign your DNAR off. So the family automatically came in and felt that they were being given up on. And I said, this guy was chain stoking, he was basically a peri-arrest, and the A&E, all they cared about was just the 4-hour breach, to get him out, get him to the ward quickly. This locum professor decided to say that, oh, well, you know, the medical registrar's a big boy, he's got a whole team, he's looking after that, you know, it's their problem, they can deal with it. And I'm thinking there's a patient and a family on the end of this, and I'm not going to let it happen. And I also said to the medical reg that this patient would be leaving, feel free, come take a seat, John. Medical reg said, I said to the medical reg that this patient would be leaving A&E with the paperwork done. So when I said to this bloke that I wanted to ring the patient, ring the medical reg and say, look, he doesn't have a DNAR form sorted, he goes, no, big boy, he can do it himself. So I went off and I did it, and then he caught me in a room, and I was ringing the medical reg saying, look, you're going to have to do this. And he, you know, I basically said to him, look, it was halfway through my shifts. I said, look, you can sign my timesheet if you want. If you don't like it, that's fine. If you want me to carry on seeing patients, I will. But I'm not going to not do that. And I appreciate locuming, it's a little bit easier because you're not there full time. But we need to start taking little steps to really improve the service that we're offering our patients or our customers. And people get upset about saying they're customers, but they are. They pay for the NHS through taxes. They basically pay our wages. And I think if we started looking at them a little bit more like customers, we might start offering a little bit more customer service to them. But that's just the retail element in me. So I'm sorry if that upsets you. Any other things that affect your consultations? So time pressures in A&E, what else? Yeah, the environment, absolutely. So how can you, what practical tips can you do in terms of, there's a speciality in terms of corridor emergency medicine, which is now doing, because we've got 8-hour waits in A&E and the days of that are coming back, sadly. And we've also got situations where loads and loads of ambulances are lined up waiting. So what can you guys do as kind of SHOs, F2s in A&E? What do you think your role should be? And if you take the mic and kind of say stuff, that'd be amazing.
I guess it's knowing that that's a priority where you have the conversation and trying to find a way of making it better so that you can have the conversation in the right place.
Okay. I think, yeah, that definitely. Just before we go to the next thing, one thing that's useful to think about, certainly if you're in A&E and you're rotating through A&E, is just have a look at the patients. And you should be able to pick out people that are unwell. And there was one guy in A&E that I saw, he was 21, he had chest pain, he looked grey, clammy, awful, and there was problems with the bed managers in terms of they didn't want to move the patients in resus and outlive somebody onto the cardiology ward because that would impact on the elective orthopaedics list on the Monday. And then the orthopaedic surgeons would shout and get upset because their elective lists are cancelled. So at that point, so when I was middle grade in A&E, I asked the boss, can I ring the bed manager? He looked at me as if I'd thrown another head. Why does he want to ring the bed manager? That's fine. And I phoned the bed manager and I spoke to them, and actually, they're all right about it. And in the end, they sorted it out, they moved things around, and they did it. But there's this perception that we shouldn't be talking to managers and we shouldn't be engaging with them. And then you get the minority of managers that just shout at people, and that kind of damages that relationship even more. So yes, there's things that we can do in our consultations with patients, but there's also things that we can do to influence the environment, which is really important. Okay, and sorry, what were you going to say? Oops.
Hello?
Hello.
I was going to say, I play trolley Tetris.
Tetris, I've never heard of that.
I move people myself.
Yeah, okay.
I just move them.
So that's cool. And in terms of another little anecdote that I've had is there's a lady, there was a patient who came in and she was misdiagnosed with an iliofemoral DVT and heparinized. It's quite a rare thing to have, but she misdiagnosed with that. She came in, I picked her up in about 3 hours, 20 minutes. So I had to make a decision in 40 minutes. Well, I had to get her out in 40 minutes. And she had sharp shooting, burning pain down the back of her right leg. Sounds like sciatica to me. So I've got that information, I've assimilated it. You see the patient quickly from the point of view, you get some more information that helps, so you get them to corroborate your story, or their story. And then I went and got some morphine, and I was giving it to the patient as I was seeing them, because playing trolley Tetris is similar. And the consultant, that upset the consultant, pulled me out. Why are you taking so long to see this patient? Or what's that? And so, well, it's morphine, giving some morphine. That angered this bloke completely, and he got really annoyed and gave me a dressing down in front of like medical students and regs and various other people in the department, and then got really sarky and saying, well, we're in a multidisciplinary team, nurses are perfectly capable of giving that. And I was explaining, and I was at a stage then in my career where I was trying to justify my actions. And then he took me away to a laundry cupboard and said, you're not lying to me, are you? So it was a very weird interaction in a laundry cupboard, seriously. And he was saying, you're not lying to me, are you? I was like, no, why would I be lying to you? You know, this is a patient I can discharge in 40 minutes if we get a decent pain relief. Writing it in the notes and leaving it there it's not a nurse's job. We need to get kind of, again, it comes down to customer service, doesn't it? And some of the stuff that I see in terms of people sitting around in pain, it's not because people don't care. It's not because they are ignoring it. It's because we are so pushed in terms of pressures, we physically can't do it. But yeah, okay, so that's very interesting. Any other stuff? Any other things that affect your consultations? So we've kind of talked some of these. Polypharmacy, service demands, highly pressurised environment, ageing population, complex needs, all that sort of stuff. So
Hello.
it does come down to money, and we're not going to change. Oh, sorry. Hello. Yeah.
Hello, my name is Diane,
Hey,
and I'm
you're
an A&E consultant.
Hello.
I'd like to make a couple of points.
Yeah, please do.
I think you had some very bad experiences because
Yeah.
what you've mentioned is
They're
not
very-
a reflection of everyone
No,
else.
I'm not saying it is, but I think it's useful to look at the worst possible case scenarios, because when you've got kind of SHOs and F2s, they need to be aware of what the worst thing that could happen is.
No, what I'm referring to is like someone putting 4-hour breaches before safety. It can happen. I've seen it happen, but it's not something that happens a lot, and not something which is universal. And most of us would not do that.
Okay, that's fine. That's good.
So if you want to come work with us, we're in Lancashire Teaching Hospitals.
I'd love to. I've got to finish the MBA and then I'll come.
Before.
No, I'm sure. Look, lots of people do, but there are horror stories, and I've locumed in that 2,500 hours. I've locumed in hospitals across the country, so I admit that they're only snapshots. But you know, I've been up as far as Hull, and I've been out to the Manchester and Liverpool way, and I've been in the hospitals in London. And yes, there are great things done in A&E. But because we can't judge the demand, when the proverbial hits the fan, things get really, really bad. And I think a lot of the stuff that's going on in the NHS in the moment is we're operating without any slack whatsoever. So in an ideal scenario, with everything's fully staffed and there's not that many patients coming in and everything's fine, I have seen instances across the country, and this is not just one A&E department, this is across the country, where the service, so to speak, has been appalling.
There's a lot of pressure at the moment because of beds and exit block, and it is horrible to work when you have 20 patients waiting for a bed in a 22 cubicle department, and there is a lot of pressure and stress. But I think the priority always remains patient care.
I'm not saying the priority is not patient care. Of course the priority is patient care. But what I'm saying is, looking at an environment in terms of trying to achieve that, it's increasingly difficult when you've got juniors juggling, seeing 2 or 3
there's
patients.
Noise.
Yeah.
And I think if I'm an A&E consultant and I've got an SHO who's seeing 2 patients an hour, I would be very, very happy, because that's not a normal average. That's not a normal ratio.
I mean, I was on the middle grade rota, and I mean, they kind of expected it. And yeah, I mean, there are variations, and I'm happy. I love working in A&E. I really enjoy it. Don't get me wrong. Not quite enough to do it full time as a career, because I think it would kill me. And I think loads and loads of doctors think, they look at it and what it does to their life. They enjoy it, and yes, it's very enjoyable. But the environment that they're in, they're not able. It's not sustainable. And that's what a lot of my colleagues are saying as well. And they're going off and doing other things. So, but yeah. So, I mean, this is interesting. This might interest you, because the next thing is, it was a call that I took when I was an orthopaedic SHO, and they picked up the phone and I took the bleep, and they said, they said, you don't admit young patients with rib fractures, do you? And immediately, that's in a setting where you've got somebody in A&E who is not a senior, they're not middle grade, they're not a consultant, they're seeing patients, they're not necessarily supervised as much as they should be, so they're ringing orthopaedics for advice, and so they're doing that because they're reaching out and they need help. So what you guys should do, if you're kind of in this situation, you're taking this for referral or you're making this for referral, is get more information. She's a 21-year-old female, road traffic collision, 60 miles an hour, going around a bend in the rain, wrote off her car, needed to get extricated from the car from the fire brigade. They found a rib fracture on a thoracic spine film, so they just found an incidental finding. It was pressurised on the phone. They were coming near the breach time. They wanted to move this patient on. It's a little bit tongue-in-cheek, but there's a phrase, spreading the blood among the tribes, in terms of trying to implicate as many people as possible in terms of if you're not sure. And then in the end, I went to see this lady, and I was the only one to pick up on she looked pale, and that was it. All her obs were normal, she was fine, nothing really a problem. And in the end, that was only because you listen to the information from your colleagues, but then you actually try and see it with fresh eyes yourself and actually make an assessment of that patient. This lady had a grade 1 liver and kidney laceration. She was a phone call away from going home, and in the end she was transferred for hemodynamic obs for 24-48 hours in the local trauma centre. So that's really, really interesting. Dealing with surgical registrars can be quite difficult sometimes. So there's a chap who's admitted with abdominal pain, ED that was pressurised, people that were seeing lots and lots of people at the same time, like 2 or 3. He was clearly unwell, and again, service pressures meant that it was challenging. When I got phoned to ask to see a patient, to go to the ward to hold a camera, I said that I was seeing a patient in A&E, and the response was from the surgical registrar, I thought you wanted to be a surgeon. So you're constantly, sometimes you're battling against the elements, you're battling against the environment, you're battling against sometimes about colleagues, and when you have a gut feeling, trust it. In terms of if you think something's not quite right with the patient that you're seeing, put as much resource into that as possible and spend longer with them, and just sidestep away from this constant, we've got to see them really, really quickly and rush through. This guy, he sadly had a leaking abdominal aortic aneurysm. He arrested on the table, went to coroner's court 18 months later, very, very kind of upsetting. And I can remember when this guy was coming around to 12 hours in the department, there was interactions with bed managers who was talking about they wanted to move the patient to outlie them to an orthopaedic ward. And that's because there's been no communication between the clinical teams and the managers in terms of what was going on. So the consultations, don't just think of it in terms of patients, think about it in terms of your MDT colleagues and include managers in that as well. I'm wondering if you guys have got any cases that you might like to talk about, just while we're closing. No? Think about them. If there are, we can come to them at the end. How do you guys do ICE? Oh, sorry, you've got a case. Yeah, we've got the mic. Okay.
Not a case, but a comment.
Okay.
You're talking mostly about a consultation in A&E setting.
Yeah.
As consultants, we face consultation in the clinics, which can also be very challenging.
Imagine.
And I would suggest that you sit in with the clinics sometimes to give, as you say, a fresh eye on the problems.
I will.
And maybe,
I can imagine it is horrific.
Quite often we have patients at a 1 o'clock appointment who wants to go on and discuss latest Daily Mail article about statins and won't budge out of my room. And
this
there is
A&E, in A&E clinics
no, this
or in
is
GP?
an outpatient clinic.
Oh, outpatient clinic, okay.
Cardiology clinic.
Yeah.
And there is a lady who has brought her old mother to the clinic and wants to go back to pick up her children from school.
Yeah.
And who is going to be irate because of the delay.
It's challenging, isn't it?
I Want Great Care is not going to give me any good rating on that.
No, they're not.
And perhaps by sitting in, you can next AGM conference suggest a few solutions to this.
Yeah, I mean, I think as a medical profession, we need to stand up and we need to shout and we need to say, well, actually, for so long, the service has been delivered on goodwill, staying later, covering rota gaps.
Absolutely. I don't mind staying till 7 o'clock to finish my clinic, but the lady who has to pick up the kids won't stay late.
No, quite.
Yeah.
But I think what we're seeing now, and certainly with the junior doctor contract dispute and people leaving, going off to Australia, I know consultants that are saying they actually feel sorry for junior doctors and they feel that they're just left bereft. And I think unless we get the public involved...
The patients are getting the voice now, but the clinicians aren't. We need a forum where we can project the clinicians' concerns,
Come to what
and not
media
just single whistleblowers.
Well.
Not single whistleblowers, but as a whole.
Don't get me started on whistleblowers. That's a really bad topic. But Chris Day has made £100,000, which is good news from a whistleblowing point of view. So his case has been kicked back to November 2017, which is less good news. But again, if you think about it, in terms of whistleblowing, it's actually really important, because if you see all these things, you need a forum and you need to be able to say, well, actually, this is happening and I don't like it, or I'm a bit unsure about this. But yeah, in terms of time, we'll kind of whiz through this. ICE, the one point I was going to say on ideas, concerns, expectations, medical students, it's always tagged into a social history questions at the end. I don't think that's necessarily the best, because sometimes if somebody's concerned about something, it's the first thing that they want to talk about. And as a medical educationalist, I'm kind of responsible, or I'm not for that bit, but I guess we're responsible in terms of forcing it and shoehorning it into social history. And as clinicians in A&E, we need to be receptive to people's concerns as soon as they air them. If that's the first thing, it might not be the first thing that we want to ask, but if that's the first thing they volunteer, we must talk about it. I'll go through this ACE system quickly. Certainly safety netting in A&E, make sure you don't just safety net, but you also document it as well. If you are discharging patients, then it's better to at least discuss them with a middle grade or a consultant who's around, then document it, and also make sure the patient is clear. Because what becomes routine for us is always novel for patients, and I think that's worth remembering generally. In terms of this, if we think of acceptance, the things that we've got to accept, the doctor has an agenda in clinic, they've got to get through their day, get through stuff. The patient has an agenda as well. Whenever these two are at conflict, then it will end up in a bad review on I want great care for either the hospital or the clinician involved. I think when there's that mug meme going around saying don't confuse my medical degree with your Google search, which is a little bit tongue-in-cheek, but I think we should be encouraging patients to know about their diseases and how it affects them, and because it empowers them. And also, as medical professionals, when we get patients come in with weird and wonderful diseases, and they're the expert patients, we should be accepting of that and know that they know not only more about their disease, but how it impacts them. And also patient choice. From a clarity point of view, you can use consultation skills models, and in medical school we use them a lot, but I think if you fixate on them rigidly, it can complicate things. So pick and mix the bits of models that are relevant to the settings that you're using and where you're in them. And then finally, ending, which also ends the talk, think of the patient taking the bus home in terms of you've got to get buy-in. Whatever you're offering to them, whether it be a blood test, whether it be a scan, whether it be a referral, you've got to get them to accept it and buy into it. And they've also got to understand what you're doing. Part of this understanding is we're really bad at requesting blood tests, looking at the results, and then not bothering to tell the patient, and they will catastrophize. They will then think, oh my god, I've got cancer, even if we're not even testing for cancer. So we need that communication to be two-way with the patients. And some of the best people that I've seen working in A&E will keep the patient fully up to date on what the results are doing and how the plan's changing, because not knowing is worse. And when I teach about this, what you think about is if you're in an airport and your plane's delayed, if you sit there and wait for 2 hours without knowing, it's worse than waiting a longer period if you do know what's going on, because at least then you can plan. And things like letting the patient eat if they're not going to go to surgery, things like saying, look, we are planning for an overnight stay, you might want to get a night bag and you want to make yourself comfortable, all that kind of stuff helps them buy into the process. Safety netting we've talked about, that's times. Thanks very much. Feel free to contact me on either Twitter or Facebook. Unless you've got any questions, we'll let you guys disappear. But please do fill out the feedback forms, because I really appreciate that. And I can kind of just chat to you guys. We don't have to do questions here. Come and chat to you lot. All right. Cheers.